Good afternoon. I am Associate Professor Trofimova Irina Alexandrovna, and my lecture today is hemolytic disease of the fetus and newborn. Hemolytic disease of the fetus and newborn is autoimmune hemolytic anemia, which occurs in cases of incompatibility of the blood of the mother and fetus according to erythrocyte antigens, while the antigens are localized on fetal red blood cells and antibodies to them they produce in the mother's body. Although more than 60 different red blood cells antigens are capable of eliciting an antibody response, significant disease is associated primarily with the D antigen of the rhesus group and with a compatibility of ABO factors. Really, hemolytic disease may be caused by C or E antigens or by other red blood cells antigens such as CW, CX, DU, K, M, Duffy, ASP, AMAS, EGGEN, Lutheran, Diega, and Keddy. Anti-Lewis antibodies do not cause disease. Rhesus conflict. Pathogenesis. Rhesus conflict, a cause of the mother is rhesus negative and the child is rhesus positive. Anti-rhesus antibodies are synthesized by the mother. The blood of the mother and fetus does not mix. The placenta is usually impervious to fetal red blood cells. Fetal red blood cells during pregnancy do not enter the mother's bloodstream. When rhesus-positive blood is infused into the rhesus-negative woman through error, or when small quantities, usually more 1 milliliter of rhesus-positive fetal blood containing D antigen enter the maternal circulation during pregnancy with spontaneous or induced abortion or at delivery, antibody formation against D antigen may be induced in the unsensitized rhesus-negative recipient mother. Once sensitization has taken place, considerably smaller doses of antigen can stimulate an increase in antibody titer. Initially, a rise in immunoglobulin M antibody occurs, which is later replaced by immunoglobulin G antibody. The latter readily crosses the placenta to cause hemolytic manifestation. Hemolytic disease rarely occurs during a first pregnancy because transfusion of rhesus-positive fetal blood into a rhesus-negative mother occurs near the time of delivery, too late for the mother to become sensitized and transmit antibody to her infant before delivery. Once the mother has been sensitized, her infant is likely to have hemolytic disease. The severity of rhesus illness worsens with successive pregnancies. The possibility that the first affected infant after sensitization may represent the end of the mother's childbearing potential for rhesus-positive infants, used urgently for the prevention of sensitization. The injection of anti-D gamma globulin into the mother immediately after the delivery of each rhesus-positive infant has been a successful strategy for reduced rhesus hemolytic disease. Clinical manifestations. A wide spectrum of hemolytic disease occurs. The severity of the disease may range from only laboratory evidence of mild hemolysis, 15% of cases, to severe anemia with compensatory hyperplasia of erythropoietic tissue, leading to massive enlargement of the liver and spleen. When the compensatory capacity of the hematopoietic system is exceeded, profound anemia occurs and result of pallor, signs of cardiac decompensation, cardiomegaly, respiratory distress, massive anasarca, and circulatory collapse. This clinical picture of excessive abnormal fluid in two or more fetal compartments, skin, pleura, pericardium, placenta, peritoneum, amniotic fluid, term hydrops fetalis, frequently result in death in utero or shortly after birth. The severity of hydrops is related to the level of anemia and the degree of reduction in serum albumin, oncotic pressure, which is partly a result of hepatic dysfunction. Alternatively, heart failure may increase right heart pressure, with the subsequent development of edema and ascites. Failure to initiate spontaneous effective ventilation because of pulmonary edema or bilateral pleural effusions result in dose asphyxia. Petechiae, purpura, and thrombocytopenia may also be present in severe cases as a result of decreased platelet production or the presence of concurrent disseminated intravascular coagulation. In severe intrauterine hemolysis, unconjugated bilirubin, which is formed during the breakdown of red blood cells, is excreted through the placenta, and jaundice is absent after birth. In severe cases, bilirubin pigment stains the amniotic fluid, cord, and vernix caseosa yellow. If hemolysis begins shortly before the birth or after birth, jaundice is generally evident on the first day of life because the infant's bilirubin conjugation and excretory systems are unable to cope with the load resulting from massive hemolysis. Undirect reaction bilirubin therefore accumulates postnatally and may rapidly reach extremely high levels and present a significant risk of bilirubin encephalopathy. The risk of development of FETUS from hemolytic disease is greater than from comparable non-hemolytic hyperbilirubinemia. Also, the risk in an individual patient may be affected by other complications, hypoxia and acidosis. Infants born after intrauterine transfusion for prenatally diagnosed erythroblastosis may be severely affected because the indications for transfusion are evidence of already severe disease in utero, hydrops fetalis, anemia. Such infants usually have very high but extremely variable cord levels of bilirubin, reflecting the severity of the hemolysis and its effect of hepatic functions. Infants treated with intraumbilical vein transfusion in utero may also have a benign postnatal cause of the anemia and hydrops resolve before birth. Clinical forms: hydrops fetalis, ecteric form, and anemic form. Hydrops fetalis. The main cause of fetal dropsy in hemolytic disease is liver failure as part of multiple organ failure, which causes of decrease in albumin production, which reduces plasma oncotic pressure. Hydrops fetalis is the abnormal accumulation of fluid in two or more fetal stains. This includes skin edema, more 5 mm, ascites, pleural and pericardial effusion. In some, this may be associated with the placental edema, placental thickness, more 4 cm in the second trimester and more 6 mm in the third trimester, and the polyhydra amnios. Epidemiology. The precise incidence of hydrops fetalis is difficult as some cases spontaneously resolve or diagnosis is not seen until fetal demise or miscarriage. The overall incidence of fetal hydrops reported in the literature is between 1 in 15,000 and 1 in 3,000 pregnancies. Hydrops fetalis is typically diagnosed during ultrasound evaluation for other complaints such as polyhydramnios, size greater than dates, fetal tachycardia, decreased fetal movements, abnormal serum screening, and antenatal hemorrhage. Ecteric form develops if the hemolysis begins shortly before or after the birth. Jaundice, the accumulation of indirect bilirubin in the lipid substances of tissues, yellow sclera, skin, and visible mucous membranes. Typical hepatosplenomegaly. There may be neurological disorders due to the toxic effect of indirect bilirubin on the central nervous system. Jaundice in newborn appears gradually, first on the face, then down. Disappears from the bottom up. The higher the bilirubin level, the larger the area has a yellow color. Non-invasive monitoring methods, including laboratory monitoring, are very important in neonatology. I remind you that the blood volume of a newborn is small, 80 to 90 milliliters per kilo for a full-term baby and 100 to 110 milliliters per kilo for a premature baby. If blood is taken frequently for laboratory testing, it is like bleeding in the laboratory, which can lead to ischemia and anemia. To monitor the level of bilirubin, we use the Kramer scale. It includes 5 zones. If jaundice is only on the head, the bilirubin level is about 100 micromole per liter. If jaundice in the first and second zone, up the navel, approximately 150 micromole per liter. If there is jaundice in 3 zones, first, second, and third, up to the midsection, the bilirubin level is approximately 200 micromole per liter. If all 4 zones are yellow, without feet and hands, approximately 250 micromole per liter. If the newborn is all yellow, including the feet and hands, then the bilirubin level is 300 micromole per liter or more. The next non-invasive method for determining bilirubin levels is transcutaneous bilirubinometry. Bili test is fully automatic measurement device intended for objective evaluation of hyperbilirubinemia level of newborn infants. It is screening method for discovering group with danger of heavy hyperbilirubinemia progress. Using of the device reduce the amount of newborn infants subject to blood bilirubin examination. The device provides possibility to the detailed observance of hyperbilirubinemia progress of newborn infants. Using the device provides also continuous tracing of therapy effectiveness. Complications of icteric form, kernicterus, bilirubin encephalopathy, and cholestasis, inspissated bile syndrome. Pathogenesis of kernicterus. Unconjugated bilirubin crosses the blood-brain barrier, and because it is lipid-soluble, it penetrates neuronal and glial membranes. Bilirubin toxicity most frequently involves the basal ganglia and cranial nerve nuclei. Risk of bilirubin toxicity. The higher the level of bilirubin, the higher the risk of its toxicity. For premature newborn, the toxic level of indirect bilirubin is more 340 micromole per liter. The toxicity of bilirubin also depends on the level of albumin. Albumin is a large molecule. If indirect bilirubin is associated with albumin, it is more difficult for it to pass through the blood-brain barrier. Preterm babies have lower albumin levels than full-term babies. Therefore, the toxic effect of indirect bilirubin can occur at a lower level of bilirubin. For newborn without risk factors, the level of toxic bilirubin in micromole per liter is equal to albumin multiplied by 10. For newborns with a risk factor, toxic bilirubin level in micromole per liter is equal to albumin in gram per liter multiplied by 8. Risk factors for bilirubin-induced brain injury: hypoalbuminemia, hypoxia, dose trauma, hypoglycemia, hypocardia, acidosis, hyperosmolarity, and prematurity and low birth weight. Clinical manifestations of kernicterus, bilirubin encephalopathy: opisthotonus, extensor rigidity, tremors, respiratory disorders, heart rate disorders, ataxic gait, oculomotor paralysis, hearing loss, loss of the suck response, lethargy, hyperirritability, seizures, death. The outcome in the future: choriatosis, spasticity, cerebral palsy, hearing loss, ataxia, and mental retardation. The next complication of the jaundice form of hemolytic disease of the newborn is cholestasis, or inspissated bile syndrome. Increase in the excretion of conjugated direct bilirubin, which can lead to a violation of bile excretion. It can develop at any time, most often after the replacement blood transfusion. Jaundice gets a greenish tint. Hepatomegaly: light feces, dark urine. An increase in the direct fraction of bilirubin, more than 20% of the total level, and other biochemical markers of cholestasis, alkaline phosphatase. Anemic form of hemolytic disease of the newborn develops when the fetus enters the bloodstream shortly before the birth of small amounts of maternal antibodies. Hemolysis is not of an intensive nature, and the liver of the newborn is quite active in withdrawing indirect bilirubin. Anemia predominates. Jaundice is absent or minimal. Hepatosplenomegaly. Diagnosis of erythroblastosis fetalis requires demonstration of rhesus incompatibility. Mother is rhesus negative, the child is rhesus positive. Antenatal diagnosis of rhesus negative women: a history of previous transfusions, abortion, or pregnancy should suggest the possibility of sensitization. The maternal titer of immunoglobulin G antibodies to D antigen should be assayed at 12 to 16 and 28 to 32 and 36 weeks of gestation. The presence of elevated antibody titers at the beginning of pregnancy, a rapid rise in titer, or a titer of 1 to 64 of greater, suggests significant hemolytic disease. If the mother has a history of previously affected infant or stillbirth, and rhesus-positive infants is usually equally or more severely affected than the previous infant, and the severity of disease in the fetal should be monitored. Assessment of the fetus may require information obtained from ultrasonography. Real-time ultrasonography is used to detect the progression of disease with hydrops defined as skin or scalp edema, pleural or pericardial effusions, and ascites. Early ultrasound signs of hydrops include organomegaly, liver, spleen, heart, and double wall signed wall edema, and the placental thickening. Progression to polyhydramnios, ascites, pleural or pericardial effusions, and skin or scalp edema may then follow. Postnatal diagnosis. Immediately after the birth of any infant to an rhesus-negative woman, blood from the umbilical cord or from the infant should be examined for ABO blood group, rhesus type, hematocrit, and hemoglobin, and reaction to the direct Coombs test. If the Coombs test result is positive, baseline serum bilirubin levels should be measured. The clinical picture is important for diagnosis. Edematous syndrome, anemic syndrome, jaundice syndrome, hepatosplenomegaly. With jaundice, the clinic kernicterus is possible. Hemolytic disease of the newborn causes by blood group A and B incompatibility. ABO incompatibility is the most common cause of hemolytic disease of the newborn. A and B antigens are located on the outer surface of the plasma membrane of the erythrocyte. Either immune anti-A and anti-B group antibodies belong to the class immunoglobulin G, and contrast to the nitrile group antibodies which belong to the immunoglobulin N class. Either immune antibodies can bind to the corresponding antigen A and be fixed on other tissues, including placenta tissues. That is why the hemolytic disease of newborn, according to the ABO system, can develop already at the first pregnancy. Although ABO incompatibility occurs in 20 to 25% of pregnancies, hemolytic disease develops in only 10% of the offspring in such pregnancies. Clinical manifestations. Most cases are mild with jaundice being only clinical manifestation. The infant is not generally affected at birth. Pallor is not present, and hydrops fetalis is extremely rare. The liver and spleen are not greatly enlarged, if at all. Jaundice usually appears during the first 24 hours. Really, it may become severe, and symptoms and signs of pernitus develop rapidly. The presumed diagnosis is based on the presence of incompatibility of ABO, mother with blood group O, child with blood group A or B. Hyperbilirubinemia is often the only laboratory abnormality. Hemoglobin levels are usually normal, but can reach 10 to 12 grams per deciliter. Reticulocytes can be increased up to 10 to 14%. Hepatosplenomegaly. The main goals of therapy are to, first, prevent intrauterine or extrauterine death from severe anemia and hypoxia, and second, avoid neurotoxicity from hyperbilirubinemia. Intravascular umbilical vein transfusion of packed red blood cells is the treatment of choice for fetal anemia. Hydrops of fetal anemia, hematocrit less 30%, is the indication for umbilical vein transfusion in infant with pulmonary immaturity. The survival rate for intrauterine transfusion is 89%. The complication rate is 3%. Complications include rupture of membranes and term delivery, infection, fetal distress requiring imaginary cesarean section, and prenatal death. Treatment of liver-borne infants includes conservative treatment and exchange blood transfusion. Phototherapy. Treatment phototherapy may be effective in lowering serum bilirubin levels. It is performed for all newborns with pathologic indirect hyperbilirubinemia. Special lamps are used that emit light with a wavelength of 400 to 500 nanometers. Meaning of the procedure: photooxidation and photoisomerization process produce a water-soluble isomer of indirect bilirubin, lumirubin, which enters to bloodstream and is excreted in bile and urine. The newborn is in an incubator for the prevention of hypothermia because the procedure is long, carried out for many hours. Eyes are covered with special glasses. Exchange transfusion. It is performed only for those newborn who have indications. They are total bilirubin levels in umbilical vein more 80 micromole per liter, rate of increase under bilirubin, how quickly increase bilirubin, in rhesus incompatibility more 7 micromole per liter per hour, and in ABO incompatibility more 10 micromole per liter per hour. Anemia in first day with hemoglobin less 100 grams per liter and proportion between serum total bilirubin and albumin. These coefficients you see on this slide. The exchange should be carried out over 45 to 60 minutes through a catheterized umbilical vein with aspiration of 20 milliliters of infant blood, alternation with infusion of 20 milliliters of donor blood. Smaller aliquots, 5 to 10 milliliters, may be indicated for sick and hemolytic infants. The goal should be an isovolumetric exchange of approximately 2 blood volumes of the infant, 2 times 80 milliliters per kilo. In rhesus incompatibility, exchange transfusion with blood of the same group as that of the newborn, rhesus negative. In ABO incompatibility, exchange transfusion with red blood cells O and plasma AB. Rhesus type should match the infants. My lecture is over, and if you have questions, I can answer now.